Good afternoon, ladies and gentlemen. I hope you had a nice lunch break, and I hope you are ready for the second part. Everybody who has been here for the first part, I think, and I hope you enjoyed, and I hope the second part would be as interesting and as interactive as the first one. So, as we said previously, we're going to have some different settlement in this part with the two presenters in each session, apart from the oncoplastic one, which it's going to be only Nicola Rocco discussing oncoplastic cases. But it's going to be the same process about voting and discussing the cases. So I think, Michalis, can you just introduce the panel, please, the panelists?
Yes, hello everyone. Moving on to the second part. For this second part, we'll have again, as I said before, of the most important features of this meeting is the interaction between the speakers and the panelists. We'll get to learn the speakers in a bit. The panelists, I'm very honored to present. First, Amit Agrawal from the UK. Hello, Amit. Welcome.
Hi, everybody.
Dr. Angelis from the UK again.
Hello, everyone.
Hi, welcome. Peter Barry, UK.
Good evening, hello.
Hi, Theodoros Kondoulis from Greece.
Hello, everyone.
Surgeon. Dr. Maragoudakis, radiology oncologist from Greece as well.
Hello, everybody.
Manolis Alustros, a medical oncologist from Greece.
Hello, everybody. Thank you for the invitation.
And Mr. Tasoulis from the UK, a surgeon. Hello, welcome.
Hi, hello, everyone.
Hi.
Okay, so we can carry on with the first section, which is about de-escalating surgery and radiotherapy. We have two excellent speakers. We know them, we love them. Is Andreas Karakatsanis from Sweden, shall I say, or just living in Sweden, shall I say? And also
paying taxes in Sweden. Sorry.
and also Irini Badiora. They're gonna present some cases which they aim to point how and in which point of de-escalation are we now. So we're gonna have the chance to discuss all these debatable issues. So Andreas, floor is yours.
Thank you so much. Thank you for the invitation. Thank you for the panel. The meaning is to more or less highlight the dilemma in some cases. That's the one thing. Discuss about that uncertainty and challenge something which is one of my favorite topics, and that would be how are we finding ourselves in a very interesting balance when new evidence is incorporated, especially when they are based on the non-inferiority principle on the one hand, and when single discipline de-escalation does not take into consideration the other treatments in the patient. So I'm going to start by sharing my screen to discuss the first case with you. I hope that everybody can see my screen.
Actually, not yet.
Yes, well, I'll just wait.
Yes, that's it.
I think that everybody sees it now. So
Yes.
this is a case to discuss the de-escalation of surgery and radiotherapy. These are my disclosures. And let's go to the case. We are talking about a 52-year-old postmenopausal lady, just went into menopause 1 year ago. And in a screening recall, we find in her left breast an area with BI-RADS 3 microcalcifications up to 2.5 centimeters. She's otherwise very nice and fit, and this is how it looks. It is in the upper outer quadrant of her breast. We are talking about a small breast without ptosis. She's very active and avid climber herself, and physical examination does not reveal anything at all. With regards to investigations, we have a BI-RADS C density. The right breast is completely unremarkable, but in the area of the left breast, we have this area of BI-RADS 3 microcalcifications, 24 by 19 millimeters, 5 centimeters from the nipple areola complex and distally to the breast. The ultrasound in the left breast and the axilla are completely unremarkable. We perform a stereotactic vacuum assisted biopsy that shows DCIS grade 1, focally grade 2. We get this strange conundrum of suspicion of microinvasion, no comedonecrosis. On the basis of this suspicion for microinvasion, a receptor status is obtained, which is not the usual case, at least in Sweden, and we get this result. We have an ER positive, HER2 positive DCIS without an accessible Ki67. So now, the first question for the audience is, what is the next step? What would you do of the following? MRI of the breasts? Would you repeat vacuum-assisted biopsy, or would you proceed to surgery?
Shall we see the results?
Yes. Okay, so the majority would perform an MRI of the breasts, a handful would do a repeat biopsy, and approximately 28% would go to surgery. Perfect. Before I go to the next slide, let's interrogate our panel here. So, since this is a DCIS and until now that would not be very interesting for any other type of discussion, I would like to hear with our surgeon colleagues to begin with. So, Mr. Barry, what do you think?
Well, I'm afraid I'm in the handful here. So firstly, I wouldn't necessarily do an MRI. I think with the density of the breast, if it's well delineated and it's generally low density, then I think we can do without that. I don't think we know that there's evidence that really doesn't change what we do. But what may change is, and depending on the technology that you've got, if one hasn't got access to, say, MagTrace and paramagnetic technology, then we might want to know a little bit more about the potential invasion. And I think then a larger biopsy may be helpful, especially if there's an area that's more suspicious. So I'd review the radiology with our radiologists, see if there's, and particularly regarding the assessment of the lymph nodes, whether if that patient is happy to have sentinel node biopsy, we could just do it upfront surgery. But if they're really keen to avoid it, then I really would like to maybe try and sample with a vacuum biopsy to see if we can rule in invasion. They won't rule it out, but it may rule it in which case it'll help our management.
So you would go for a second vacuum-assisted biopsy because we have already done a vacuum-assisted biopsy.
Yeah, we review that if there's maybe another region of interest that may be more revealing. If we have paramagnetic technology, which I do currently, then I would probably exercise my rights to do delayed SNB according to the Sentinot paper in Annals of Surgical Oncology. So that's what would be my favored treatment, and I proceed to surgery, explaining that to the patient.
Okay. Mr. Tasoulis, what do you think about it?
Yeah, I agree with Peter. I would also not do any further imaging. I think we have pretty good quality data to suggest that MRI in this setting is not particularly useful. It does not really change the plan for surgery unless it unnecessarily leads to mastectomy. It does not reduce re-excision rates for DCIS. So I would not be very keen to do an MRI. And as Peter said, I would discuss with the radiology team if we already have a vacuum biopsy which did not really show invasive disease. I would either proceed straight to surgery, or if there was significant suspicion, I would repeat the vacuum excision, try to get a bit more tissue out.
Okay. Let's reveal that we did not have any extra suspicion. We did our homework. Amit, what do you think about it? What would your algorithm be in this setting?
I answered MRI. Well, I could argue both ways. One, why did I ask for it? Because probably that's what we do. There's lots of MRI trials, and But equally, I agree with panel answers before, and we've published the data in Cancer Treatment Reviews about 3 years ago, looking at the role of MRI in oncoplastic breast surgery. Number one, I agree, it doesn't reduce the mastectomy rate. Perhaps it may increase. Number two, it doesn't reduce the re-excision rate. I agree. Number three, does it help with oncoplastic planning? That's where probably my rationale would be asking for the MRI. If there was a slightest suspicion, the distance from the nipple, whether there may be non-mass enhancement on MRI, does it need further biopsies, those kind of, to assess the extent so I can plan surgery. But yeah, it's there's not much of data, and as I said, it was a review and we didn't see much of data regarding that.
So, and let's ask my colleague from the same unit, Irini, what do you think? What would you do?
Well, I would not go for the MRI unless there was significant obscurity in the mammograph and we needed more information. But if we have clear calcifications and there's like a delineated area, then I would not go for that.
Okay.
Well, since we're doing Sentinel in our institution, I would go directly to surgery. But if that wasn't a choice, I would definitely repeat biopsy to rule out invasive disease, and I would not go to surgery and a sentinel node just in case. I'd rather
Okay.
do one more biopsy than do a sentinel node.
Lovely. Okay. Let's put these things into context. So, MRI for breast in the DCIS, it is exactly as our speakers told us. I have just put here the IRCIS French randomized trial. It is the only randomized trial exclusively on DCIS. There is a previous meta-analysis of observational studies by Fancellu 10 years ago, and actually nothing changes with regards to re-excision rates after BCS or upgrade rates to invasive cancers or size and grade of DCIS or invasive cancer per the French trial. Interestingly, we might see some contrast enhancement in a non-mass pattern if we have DCIS grade 3, but usually DCIS grade 1 and 2 do not tend to form neoangiogenesis, so this does not render MRI more helpful in that setting. To move to the next step, there is a very clear evidence on that the upgrade of DCIS to invasive breast cancer primarily depends on the method of sampling. So vacuum-assisted biopsy, this is a paper from Korea, a quite large one. Vacuum-assisted biopsy and against core biopsy has a higher probability to pick up invasion, but in this paper and in a couple of others that I found in the literature, repeating a vacuum-assisted biopsy does not significantly increase the risk of underlying invasion, of picking it up preoperatively. So, and in this setting, since our ultrasound was not at all informative with regards to swollen lymph nodes and so on, we would not proceed with a resampling. One thing that I think that is interesting is to discuss the risk of microinvasion, and when you get a hormone panel, how can that kind of shake us? Sometimes this was a HER2 positive DCIS. We know that approximately 35 to 40% of DCISs are HER2 positive, but that does not mean progression to HER2 positive invasive breast cancer. And the studies that have looked into the recurrence risks are quite heterogeneous in that this is a DCIS that will always have a higher recurrence rate as DCIS or as invasive breast cancer. What we know, and this is mostly a perspective paper that I put up here, is that there is a tendency to consider HER2 positive DCIS as high risk DCIS regardless of their nuclear grade. So back to surgery, that's a small breast. We need approximately a quadrantectomy, and as these ladies usually are, they've got a narrow chest wall and they've got very thin skin flaps and lack of persuasive donor sites. She does not want any asymmetry and she opts for single stage surgery no matter what. So what is the next step? What would you do of these cases? Let's vote. Should we see the results?
Just a second, Andreas.
Yes.
We
Yes.
just give them some time because they need some time to read and vote. And moreover, just brief them with the abbreviations because most are not
Yes.
familiar with
Breast
DTI,
conserving
direct to
surgery is
implant.
BCS, MX DTI, mastectomy direct to implant, or a tissue expander or an autologous free flap. I think we've got a result, and the majority would go for a chest wall perforator flap. Just to discuss on that, this is clearly a case where the quadrantectomy is sufficient to discuss more advanced options, since we are not left with enough breast tissue to be able to reshape the breast just with a volume replacement procedure. A mastectomy in this case would be a little bit challenging, because if one were to reconstruct that immediately, we have very thin skin flaps, we could not accommodate big volumes. We will proceed just by showing these two studies that show that chest wall perforator flaps can work as surrogates for mastectomy and can preserve small breasts even as a single stage procedure. Would you offer sentinel lymph node biopsy? Some people have touched on that already. Let's move with the voting here. So you have discussed on a chest wall perforator flap that will remove the upper outer quadrant. What do you think? Should we go for an upfront sentinel node biopsy or not? Should we see the outcomes of the voting?
Oh, it's 50-50.
Okay. That's a nice one. So that gives us good ground to proceed with the discussion a little bit. So we know that factors.
Andreas, maybe it's
Yes.
better if you ask one of the panel to support the first answer and the other one to support the other one.
Okay.
If we
who will
can we go back? Can we go back?
Yes.
The previous. Okay.
So
Can
who
we
will
have
do
the
an
poll
upfront
results?
sentinel node
Poll
biopsy?
results on. Poll results up to the screen. So can anybody from the panel support the yes central lymph node biopsy?
Is anybody interested in doing an upfront sentinel lymph node biopsy?
It's in the upper outer quadrant. Obviously, it's not going to be easy to be done later on if you have invasion. So you will probably need to do axillary lymph node dissection if you get failure of the central lymph node biopsy on the second place.
In all honesty, if I did not have access to the techniques that I have, this is a case where I would go for an upfront sentinel lymph node biopsy, because I do not believe that anybody feels that it would be, even if it were feasible, that it would be accurate. We would have to demolish the entire lymphatic outflow towards the axilla by interposing a chest wall perforator flap in there. So the notion to offer it is that of the at least unsafe axillary mapping, if that were possible.
I think
Now,
Amit wants to say something. I
yes.
think he raised his hand.
Yeah, well, I answered no, but I'm happy to discuss yes. Yeah, for one reason Andreas just alluded to, literally, if you're doing chest wall perforator flap, you have disrupted lymphatics if you're going along upper outer scar. And second, if you have used lateral thoracic artery perforator, and if you haven't done enough, then you would be nervous going back. And third, I suppose, might be the argument for there's a bit of a diagnostic uncertainty unless we were to revab or something of that sort. So those might be my reasons to consider yes, although I voted no.
Yes, just to clarify, it's not a wrong option. It is an option. Even in the NCCN, if you have in that position a tumor with DCIS removed, you are allowed to do central lymph node biopsy. So it's not a bad option. 51%. It's right to do it if they don't have the technology, as Andreas said, to do something else. So Andreas, please carry on.
Correct.
Okay, lovely. So yes, just to summarize that, it is important to remember, especially after the new ASCO guidelines that suggest that we should be doing it only in the case of mastectomy, that things are not that hopeful after previous breast conserving surgery, and there are challenges with regards to that. This is where the sentinel technique comes in. We will not elaborate much more on that. I am obviously biased since this is, in some sense, our baby. And I know that Peter is also biased in favor. So I will just say, if you had the possibility, would you offer sentinel lymph node? Yes, no, or would you opt for a delayed sentinel node biopsy? Let's vote.
Just to explain everybody who doesn't know what is a sentinode, is you use this paramagnetic substance, which is the MAC tracer, and then you do the operation without doing anything to the axillary lymph node. And then when it comes back the results and you have an invasive disease, you can go back and do a delayed sentinel lymph node biopsy by using this technology.
Exactly.
Just for those who doesn't know what is sentinode.
You mark it in case you need it. That's the idea.
The only drawback is the cost. Otherwise, there's no other side effects.
We can discuss about that, but let's see the vote results.
Okay, can we see the results, please? Okay.
Okay, so things are a little bit clearer now.
So I think Amit is unbiased and raised his hand.
Yes, Amit, shoot it.
Sorry, it was legacy hand, but
Ah.
I've shifted my vote to Sentinode, although I haven't done it. So perhaps the rest of the panel who are biased can explain what it is to help with the split.
Can I just mention slightly too technical note maybe, but very technical, but I did this yesterday. I did a combined LTA LICAP flap for an upper outer quadrant tumor, very similar to this. And I did a sentinel node, but I did not skeletonize the LTA at the time. I didn't pendulum the flap. So I had a minimal dissection, I would say, just required for adequate mobilization. And I think it's important that if there's a chance of coming back, that you do as minimal possible to expose those vessels in the initial surgery. So if you do need to come back and clear, then it's not already, shall we say, surgically scarred. Yeah.
Yes.
Yeah.
Agree. I agree. With regards to the costs, what I would say is that in the study results, we saw that if you compared the costs across the entire cohort, we had a cost reduction of 10% in total for patients like this one that had a DCIS. Sentinode would have resulted in approximately a 29% cost reduction. And the reason for that is that you pay for the MAC trace, but you are skipping the pathology costs for the sentinel lymph node diagnostics afterwards at the lab, which are approximately 4 times more expensive than one shot of MAC trace. So this is what we got here. We got a grade 3 DCIS, 3 centimeter largest diameter, a minimum margin of 5 millimeters, no microinvasion or invasion, and this is how it looked like now. So the HER2 was completely negative. We had the low Ki62, so it's an ER positive HER2 negative DCIS that has been removed with breast conservation with a minimal margin of 5 millimeters. Now, what would the adjuvant treatment be for you in this case? No adjuvant treatment, whole breast radiation therapy, whole breast radiation therapy with endocrine therapy, accelerated partial breast irradiation therapy alone, or accelerated partial with tamoxifen. Please choose.
She's 52 years old, just to remind everybody.
Yes,
52-year-old lady.
Just entered her menopause, and she's got what we call a good risk DCIS.
Okay, can we see the results, please?
Yeah. Okay, so the majority would go for both here. They would go for whole breast radiotherapy and endocrine therapy with TAM.
I think we have Mr. Maragoudakis with us.
Exactly. And now I'm going to turn to the radiation oncologist and to the medical oncologists in the group. Please, what are your inputs? Mr. Maragoudakis.
Yes, that's what I vote. I vote number 3. I would recommend radiation therapy and tamoxifen.
Fantastic. The input from our medical oncologist, Mr. Salustros.
Yes, thank you very much. I voted also for the option 3, but as you all well know, it's a matter of discussion. It's a matter of perception of risk. It takes some time to discuss with the patient the benefit that she may have for both modalities. If I made a quick calculation, and the estimated risk of recurrence in 10 years is about 15 to 20%. You all know very well the reduction by radiation and tamoxifen. We could consider also anastrozole here because it's a postmenopausal. And according to NSABP B35, the women who benefited the most from the AI versus tamoxifen were those below the age of 60 at the time of diagnosis. So I voted for 3, as I said, but I will spend a lot of time for discussion with the patient.
Okay.
Fantastic.
Mr. Angelis, what did you vote and why would you go for what you voted?
So although we've got some good data with NSA B24 about the use of tamoxifen and DCIS, we seem to veer off from that practice at the moment. Currently at Barts, we tend to offer tamoxifen for DCIS when they have additional high-risk features. But it is something that we know there's evidence, and also there's evidence for lower dose tamoxifen, really, for patients that can tolerate it.
This is why I put tamoxifen to discuss the baby tam option.
Yes. So in essence, we basically know that also the TAM1, I think it was, that showed that the 5 milligram dose is. So I think that's something that we have to fall back on if our patients struggle with this approach. So generally, we tend to start though at full dose, but if there's any issues of tolerance, we do drop down to 5 milligrams.
Lovely. So just a little bit of context to that. We are familiar with the RTOG 9804 trial. Now, this trial that looked at the omission of radiotherapy for good DCIS still showed that we have a very markant difference in the relative risk reduction. It remains a relative risk reduction of 50%. Now, that particular patient would not have fitted that because she was 30 millimeters at pathology, but I just put it in there just for the discussion. A little bit for ABBI. So ABBI seems to be comparable in terms of control, but we do have higher acute and late toxicity and worse cosmetic outcomes. So we know that whole breast radiotherapy for DCIS consistently has been shown to halve the recurrence risk, and that has been the constant finding in 4 randomized controlled trials that are summarized in this forest plot by the Oxford group. And with regards to endocrine therapy, the best available summary of evidence comes from John Boyage's group in Australia. With this paper, I have summarized the outcomes for you. What we would gain in this particular patient would be probably the reduction of the invasive local recurrences and the contralateral events, of course. And as it was alluded by Mr. Salustros, this is a discussion with the patient, and issues of tolerance, as Mr. Angelis commented on, should be discussed in this context. And with that, I would like to thank you, and we can move over to the next one.
Okay, so probably Irini Pandiora is going to share her screen with us now, isn't it,
Yes.
Andreas?
Yes.
Let's see. Does everyone, oh, let me check. No, sorry, I'll just do it again.
You should share your whole screen, not just the application, just to share
Entire
screen,
screen, yes.
entire screen, exactly. Thank you. That's it, and then.
Okay. Great. Thank you for inviting me. This has been a very interesting discussion. So I will just talk about de-escalating axillary staging and invasive cancer. So our case is a 49 premenopausal woman. She's selected from her screening mammogram with a 15 millimeter BI-RADS 5 lesion in the right breast upper outer quadrant. In her history, there's only 2 cycles of IVF, and in her family history, she has a grandmother with a breast cancer at 64, so nothing significant there. Her last screening was 2 years ago per the national protocols, and she doesn't have any comorbidities. She has a CAP-B breast and a BMI 24. Clinical examination did not reveal any findings, neither in the breast or in the axilla, and this is the mammogram of the tumor. Core needle biopsy revealed a ductal cancer grade 2, hormone receptor positive, HER2 receptor negative, with a Ki67 at 17%. And we also did an ultrasound which confirmed the lesion in the breast and no suspicion lymph nodes in the axilla. So this is my first question. Genetic testing might look a bit overkill here, but per the new ASCO guidelines, we should do to any women younger than 64. What is an appropriate next step? Is it mastectomy and sentinel node biopsy, breast conservation and sentinel node biopsy, or mastectomy or without any axillary surgery and breast conservation without axillary surgery?
Can we see the results, please?
Am I the one who has the results? Oh, there
Don't
they
worry.
are.
Here they are. So most people voted for breast conserving surgery plus sentinel lymph node biopsy, obviously. Would you like Marios to discuss it?
Yes, I mean, there is a trend towards de-escalating axillary surgery for women with early stage indolent breast cancer. And we do have some data now to suggest that this is feasible and potentially safe. But I'm not sure that for this woman, this would be the most appropriate step, as it does not appear to fit into the cohorts that have been looked into, meaning that most of the randomized data that we have included women that are above the age of 49 and mostly postmenopausal, and she was young and premenopausal. And the most recent ASCO guidelines that do support omission of sentinel lymph node biopsy, they recommend it for women who are postmenopausal and above the age of 50. So for this one, I would support breast conserving surgery and sentinel lymph node biopsy.
Okay, Irini, would you like to address any question to the panel, just for the sake of discussion, or are you happy to discuss anything or carry on?
I just want to ask if there is anyone who would omit sentinel node biopsy on this patient.
I mean, obviously not from the panel, I guess, but
No,
there
yeah.
are some people in the audience that they would have done it. So maybe you should give us some
Yes.
explanation. Yes, carry
The
on.
reason why I put this patient is because she is 49 years old, so she's at the margin where some people kind of define menopausal, and she's clearly premenopausal. She does have a small tumor, so she has a T1 tumor, grade 2, nothing too aggressive. But I wanted to show this case because the 2 randomized trials that we have included T1 or T2 tumors, and they kind of had like a wide umbrella. The thing is that these populations, if you see here, were underrepresented. So most of the patients, like Mario said, were older women postmenopausal. Very few women were younger than 50 years old in the INSEMA trial. And very few women were, again, younger than 50 in the SOUND trial. So we tend to kind of make it a mantra when a new study comes and kind of include patients indiscriminately. And I wanted to just see that there are traps in this. We should select our patients very carefully when we decide to adopt a new method or a new de-escalation technique. And these are the ASCO guidelines. They stemmed from the trials, but they were a bit more conservative, and they limited their selection population in older than 50 small tumors, grade 1 to 2, and only ER positive, HER2 negative patients who are intended to receive endocrine therapy and breast radiotherapy.
Well, your patient was pretty close to that, though. That's why I was in the slightly close zone to that, isn't it? It's just the
Yes.
2 years of age, the difference. I mean, if she was 51, would you consider omitting the sentinel lymph node biopsy in this patient?
Well, if she was postmenopausal, maybe, but we will see as the case develops here why we
Okay.
did not do that to this patient. Let's see. So when it comes to breast surgery, we went for breast conservation with perforator flap reconstruction. And we had on the pathology report an 18 millimeter tumor with clear margins, ductal cancer grade 2, similar to the one that we had on the biopsy, no big changes here. And the type of surgery is also significant here. And I want to hint to that when we come to the next questions. Would we go for axillary staging here with these results in the pathology report or not? Would you decide that you don't need them? It won't change your treatment plan or not?
So you should actually read the questions now because they're
All right.
quite complicated and they need time to
Yes.
read them. So just read them for this, please.
Yes. So if we decide that we don't want any axillary staging, that's the option number 1. We would go for whole breast irradiation and endocrine treatment with tamoxifen or tamoxifen and then change to aromatase inhibitors. If we want to do the sentinel node biopsy, then we have the following options. If it's positive, then we go for whole breast and regional node radiation with chemotherapy, with endocrine therapy, either tamoxifen or aromatase inhibitor with GnRH analogs and ribociclib 3 years. The second option for a positive lymph node biopsy is whole breast irradiation with regional node irradiation and genetic signature. And if there is a low risk, then tamoxifen or aromatase inhibitor with GnRH. The third option for a positive lymph node is whole breast irradiation plus minus regional node irradiation with genetic signature. And if that is low risk, then we go for endocrine treatment plus ribociclib. And the last option is whole breast irradiation with chemotherapy and endocrine treatment. And I'm sorry, I can read the last of my page. And ribociclib 3 years without the genetic signature.
So lots of combination here. I think
Yes.
they will need some time to decide which one is the best option or the most appropriate option, let's say. Okay, can we see the results? So you're gonna probably need a medical oncologist and
Yes.
radiotherapy and surgeon for that.
Yeah, I think that kind of includes all specialties. Could we hear from the medical oncologist first?
Yes,
Dr.
thank you. A lot of options, but regarding chemotherapy in case of a premenopausal women with a positive lymph node, we don't have the tools to select many patients that will not get any benefit from chemotherapy. The results from our responders were pretty clear with some benefit from the addition of chemotherapy. I'm aware of the results of other genetic signatures that support the option to avoid chemotherapy. But although I believe that this is a low-risk tumor, I mean, it looks like a luminal A-like tumor, and the benefit from chemotherapy could be not that much. I tend to offer chemotherapy to premenopausal women with involved lymph node. Regarding adjuvant therapy or adjuvant hormonal therapy, you are all aware of the results of the NATALEE trial. The estimated benefit here regarding the IDFS is around 5%. Of course, this is another discussion here with the ovarian function suppression and the hormonal adverse events, but my option would be chemotherapy plus hormonal therapy with ribociclib.
So no ovarian function suppression.
Ovarian function suppressor is recommended when you use ribociclib Sofoclis because the combination is aromatase inhibitor. So you have to give ovarian function suppression plus aromatase inhibitor plus ribociclib.
Okay.
Can I just ask something? If you didn't have the status of the lymph node, would you omit chemotherapy, or would you want to do a genetic signature test?
Yeah, I would bet that the recurrence score here would be low. So I will definitely go for an Oncotype DX score, and I would hope to avoid chemotherapy for this lady.
Okay. Shall we carry on?
Just
In
to
case of a no
to
negative
intersect and
result, right?
mention something. Sorry. There's one thing to mention is that you can really not give tamoxifen and ribociclib in any occasion.
Yes.
These two drugs are not able to give together, so we just need to bear that in mind, even if you use ovarian function suppression or not. And as my colleague said, I think we all still practice based on what Alex Ponter indicated, and we offer chemotherapy for premenopausal women. But I'm sure you might have seen a little bit of data recently presented at ESMO Breast, where basically a lot of our colleagues in the US are starting to use the RS-CLIN score for premenopausal women that are node positive and have very low oncotype. So this is possibly something that might change at some point soon.
So what would be the option for you, the right option?
I would also offer chemotherapy at this stage we are with the data we have, chemotherapy followed by ovarian function suppression and aromatase inhibitor, because that's what you do for a premenopausal woman, plus ribociclib because she's N1.
Okay, thank you. Can we carry on, Irini?
I think there's a question from one of the panelists, Mr. Kontoulis.
Yes, I would like to ask the medical oncologist if she was perimenopausal, would have changed anything between 5 or 6, meaning they will do a genomic testing or chemotherapy anyway. If she's perimenopausal.
At least in my practice in the UK, we class perimenopausal women as premenopausal, so we treat them similarly to premenopausal women.
Would you do an anti-Mullerian hormone investigation to see if to check the ovarian function reserve or not?
It's an interesting point. I think we have data for this. We don't routinely do this at the moment, but it would be quite something that we might consider doing in the future.
But this applies to women after the age of 50, I think.
Yep.
Yeah.
Can we carry on?
Okay. Let's see. So, yes, we did sentinel node biopsy on this patient, and we did have 1 lymph node out of 3 with a 4 millimeter macromet and an Oncotype DX score of 15. So I just wanted to show the difference between having the sentinel node, the lymph node status, and not having it. If we didn't have any lymph node status on this patient, we would have gone with radiotherapy and some kind of endocrine treatment. And this patient could actually avoid chemotherapy with the Oncotype score that she did have, because we know that from TAILORx that patients under 50 only had a moderate benefit from chemotherapy if their score was higher than 16. So she would have completely missed her chemo. Now that we did have her lymph node status, we went with radiation, of course, endocrine treatment, chemotherapy, and ribociclib, because in these cases, it is only the lymph node status that would make a difference. If this patient didn't have a sentinel node biopsy, we would not know. She doesn't have a high Ki67, she doesn't have a high genomic score, so she would miss the treatment with ribociclib. And these are the small differences and the reason why I think we should be careful when omitting sentinel node, especially in these borderline patients. I mean, of course, it would be different if we had a 75, 80-year-old patient, but these patients that are close to the criteria, the inclusion criteria, I think we should be a bit more conservative when we decide to omit sentinel node biopsy. And in this particular patient, it would be very hard to go back and do the sentinel node biopsy in order to see if she would be a ribociclib candidate because of the type of surgery that we did. So I think that was all from me.
Thank you very much, Irini. Obviously, this is the reason why under 50 is not really wise to omit axillary surgery, because we still need the info from what I get. But maybe in the future, we'll not be so stick to the information when other studies come up. But up to now, I think these are the data, and it was clear the way you presented that. I think we should carry on with the second part of these presentations. Michalis.
Thank you, Irini. Very interesting. I had a lot of questions, but anyway, let's move on because we're 5 minutes behind. I have the honor to call to the podium Bahadir Guluoglu. Bahadir, you are there. Hello, hi.
Good to see
Bahadir
you.
is going. Hello. Bahadir is going to talk to us about about special considerations we may have in the management of the recurrence. Thank you, Bahadir.
Thank you very much. I think I will be sharing this session with Yazan together. So what we will do is I will mostly concentrate on the recurrence in the breast, and Yazan will be giving a presentation about the axillary recurrences. So we have 35 minutes. That means that a little bit more than 50 minutes for each of us. So this is not sorry, let me find the correct, here. So if you can see my screen, please let me know.
Yes, if you can full screen it.
I will do it immediately if you just confirm that you're seeing it. Is that okay?
Yes.
Yes, good.
Okay, perfect. So thank you very much for the kind invitation. As I said, I have only a little bit more than 15 minutes to present you two main cases, but what I will do is just to give a scenario. These are not real cases, but in order to give a light into this topic, I just made some modules on the same patient and to let us know what the opinion of our panelists about this case. So these are my disclosures. So let's start with the first case. This is a 61-year-old female patient, postmenopausal, and she had breast cancer 7 years before when she was 54 years old, an invasive breast cancer up at the upper outer quadrant of the right breast, which the breast was a C cup size, a 23 millimeter solitary cancer, and the sentinel node was negative, and two nodes were retrieved, and none of them were positive. So T2N0, M0 grade 2, ER 90%, PR 80% positive, HER2 negative, and KI 67, 20%. So she underwent at that time, 7 years before, breast conserving surgery with 3 millimeter clear margin and the sentinel lymph node biopsy with no node involvement. So she received a 25 times 2 gray whole breast radiotherapy with a boost for 5 days, followed by AI for 5 years. So she completed the AI for 5 years with the full compliance. So today, the physical examination revealed a 1 centimeter lump at the upper outer quadrant right breast, which is the place where the primary surgery was done, and no palpable ipsilateral axillary lymph node was revealed in the physical examination. The mammography and the breast ultrasound showed a solitary mass 30 millimeters, and ipsilateral axilla was normal. So no family history, no associated diseases, and the core biopsy for this new tumor was invasive cancer grade 2, ER 80%, PR 80%, HER2 negative, KI 67, 25%, which is much more the same with the previous tumor 7 years ago. So the patient says that I want to have, again, a conservative surgery, but in fact, in our unit, let's say there is no EURT is available. So the first question will be, what should be the next best step for the patient's assessment? So first, breast MRI only or systemic screening only for the distal mat without any breast MRI, both breast MRI and systemic screening together, or no breast MRI and or systemic screening. Please vote. So can we have the results?
I think Bahadur should give them a little bit more time to decide.
Okay. All right. So
Okay.
let's make it 20 seconds next time. Okay. Right. Here, the majority says 63% of the audience voted for both breast MRI and systemic screening. So here I would like to ask, if I'm allowed, I would like to ask first to one of our surgeons, what would they prefer? And then a medical oncologist for the systemic screening especially, and their opinion about this. So who would like to make a comment? Should I just point someone?
Yes, you can be. You probably need a surgeon here.
So if
Yeah.
So Peter.
Yeah, look, I think the MRI, we'd certainly have a lower threshold in the case of recurrence, local recurrence, where a patient's keen to conserve the breast. It's index quadrant. If it was a BI-RADS A or B and it's very clear cut, we could perhaps argue that it's not necessary, but I'd certainly, as I say, have a lower threshold than in the primary setting to do one. And in this patient, she's got a Ki67, I think it was 25% from memory. So I think a PET CT wouldn't be unreasonable in this lady. And we're particularly wary of aberrant lymphatic drainage, of course, but distant disease. And I'll stop there. So I would have chosen, I think, given those comments and qualifications, 3. Yeah.
Okay, thank you very much. Anyone of the medical
Bahadur, should we call for a medical oncologist opinion as well?
Yeah. Now I'm asking to one of them, but I don't know exactly who is the medical
I'm here to
oncologist.
help. Yeah. Manolis Alloustros is your man.
So thank you very much, Michalis. I think this is an opportunity to emphasize that no screening for systemic disease is recommended for tumors at least stage 1, at the primary diagnosis at least. It's something that I see it very often in my practice, that the women came to my office with CAT scans and bone scans, and they have a tumor like this. This is a different story. We have a new tumor, either a recurrent tumor or a new primary. So this is associated with a higher risk of systemic disease. And I would consider systemic screening in this case, but I'm not sure that it will offer that much.
Okay.
But the main point is that at primary diagnosis and of course during follow-up, the systemic screening for metastatic disease should be limited and directed by symptoms and the findings from physical exam.
So we do some systemic screening in this case. Bahadur, you may go on.
Okay, thank you very much. So let's move on to the next slide, but I can't move it. I don't know why. Yeah, now, yes. So after this, what is the next best step for the patient's management at the breast, not the axilla? Anyone of you who would just say that no surgical treatment, please press 1, only the systemic treatment. Those who favor radioconservative surgery, only press 2. Choice 2. For choice 3, radioconservative surgery with the whole breast radiotherapy, because there's no option for EURT, but we may discuss it in the panel. And the choice 4 is mastectomy, whether it's a skin sparing with an implant or not only. And the 5th choice is the mastectomy with the chest wall radiotherapy. In this case, let's say the sentinel node was negative. A redo sentinel node was done and it was negative. So let's vote. I'll give this time 20 seconds. Is it okay, Sophocles?
It's fine. Yep.
Okay.
I think we should ask one of our surgeons here to answer, and perhaps one of our radiotherapy oncologist as well.
But before seeing the results, or
no, we have to see the results.
Yes, let's see the results. Let's see the results.
Okay,
I'm giving a heads up.
Okay. So here we have the results, the radioconservative surgery and mastectomy, as you can see. Radioconservative surgery with the radiotherapy or just the mastectomy. They are head-to-head, 40%. So very few said no surgical treatment, only systemic treatment, which is just predictable. And only, I was just wondering about this, choice 2 was favored by 10% of the audience. So I'm just closing this and would like to hear somebody, a surgeon first, their opinion.
Mr. Tasoulis, can you tell us what you have voted for?
Personally, I voted for repeat conserving surgery and radiotherapy, but I think we have to make it clear that most practices, in most guidelines, the standard recommendation is completion mastectomy, although we have now increasing data to suggest that a mastectomy in this setting, meaning more than 5 years from the primary diagnosis and favorable tumor characteristics of the recurrence, then mastectomy has not been shown to provide survival benefit. And therefore, if it is technically feasible to remove the cancer without compromising the aesthetic outcome, I would favor the repeat breast conserving surgery approach.
If we move to Sweden, what would be the practice there? Do you have Irini or Andreas with us?
I don't know if they are with us here.
No, because they're enjoying the nice weather, not very common in Sweden. Dr. Maragoudakis,
maybe, yeah.
Bahadur, if I may, I want to ask a radiotherapy oncologist's opinion to see if Dr. Maragoudakis would be happy to re-irradiate an already irradiated breast 7 years ago.
With boost.
Well, I voted number 3. I agree for conservative surgery plus radiotherapy since the lady is willing to keep her breast, but I don't see the reason to irradiate the whole breast. Since we have a local recurrence, I think that partial breast irradiation with some margin around the tumor bed, the second tumor bed, would be enough. I don't see the reason to irradiate the limits of the breast. So it's a practice to the hospital where I work. If the lady is willing to keep her breast, to have conservative treatment with wide margins possibly, if possibly, and we re-irradiate, but not the whole breast, just the tumor bed with about 2 to 3 centimeters surrounding the tumor bed.
Fantastic. Sano, I can see you, but I really have to move on.
I think it's an important
If you want to say
comment.
one word, yeah.
It's important because Bahadur, you said, or you mentioned twice IORT, and I think IORT is inferior of external beam radiotherapy and it's inferior of interstitial brachytherapy. So the two techniques we might use for that, for partial breast irradiation, I completely agree with Vangelis, is we could use interstitial brachytherapy or external beam radiotherapy with IMRT.
Okay.
Excellent. Thank you very much. So let's move on. The next case is, I can't move on.
Bahadur, you should click on the screen and then you can move on.
Yeah, thank you. Okay, so this is the same patient with only the surgery was just 2 years before. So she was 59 years old. So anything would be changed in your decision on the surgery here. So I will not be reading all the case from beginning to the end. So everything is the same. Just the difference here is the patient still 61-year-old, but this time she had the surgery 2 years ago. So what would be the next best step for this patient's management? Would you still prefer to give the whole breast radiotherapy or IMRT for this patient as well after redo conservative surgery? Please vote.
And can I add that she has this recurrence while she's on endocrine treatment?
Yeah. Still on endocrine. Exactly. Yes. During
Let's
the
vote.
Yeah. Let's vote.
Let's vote.
Five more seconds.
Okay. Yeah. Let's see the results now.
Yes. So here more people chose mastectomy only here. So Let's start from again, maybe a radiation oncologist would comment on this because they were favoring about giving radiotherapy. But here, as we can see that most of the audience just changed their mind, and because there was just the interval is 2 years, so they didn't think that a second radiotherapy would be an option for this patient. So Mihalis, please help me.
Thanos, I think Thanos needs to, yeah.
Okay, thanks. So I mean, the time interval now it's really short, and I would go for mastectomy in that case because I would be afraid of side effects. And I don't know if it would be possible to apply a significant dose to the patient, even if using partial breast irradiation in that case.
Okay, Peter was raising his hand in the first case. Would you like to comment on that? And this, well, it's Peter.
Yeah, actually, I was going to ask our radiation oncologist if they're happy to re-radiate a patient who's already had a boost in the same quadrant, in fact, in the exact same place. So there was a question, really. In this case, I would just add that it's a very short disease-free interval, under 4 to 5 years, which is sort of thought to be a bit of a barrier. So I think, we've got very great concerns, and including biologically, which Michalis raised, that she's still on endocrine therapy. So this is, I mean, the systemic therapy is going to be more of a challenge. But I agree that if we can't irradiate, I mean, there's still, she could insist on surgery only in terms of local excision, because you could argue that systemically she's more likely to relapse in terms of the tumor biology. But yes, I think standard treatment, I would be pushing her probably a bit harder to have a mastectomy, even though there's probably no survival benefit.
Okay, thank you.
I saw Amit raising his hand. No, Amit?
Well, I raised my hand asking very similar question to Peter because she did have boost radiotherapy and it's recurred within 2 years. So it's clearly, it may be innate resistance to endocrine therapy, if not acquired resistance, if not innate. So yeah, so sharing similar concerns, but I lowered my hand once Peter answered.
Okay.
Okay. Let me go to the next case. This time, this recurrence is not at the upper outer quadrant. The same patient, the same scenario, but this time, this recurrence happened in the lower inner quadrant. This looks like, again, 7 years before she had the operation. This does not look like a true recurrence. It's like a secondary primary. So what would you do in this case? Again, please vote.
Can we see the voting box, please? Thank you.
So would you do something different when the patient has a secondary primary, a new tumor, instead of a true recurrence?
I think I would like to ask some surgeons.
Yeah, still the patient, 61-year-old. Yeah, please remember. Okay, let's see the results. So here, the majority says, yes, I would redo conservative surgery with the radiotherapies since 7 years elapsed from the first operation. So because maybe the patient is 61-year-old, because I'll ask this question with a younger patient, the next one. So who would like to comment on this?
I think we haven't asked Thodoris at all. Sorry, Thodoros, can you tell us what you have voted?
I voted number 3,
Okay.
breast conserving surgery and whole breast radiotherapy. It's a unifocal. It's we have a favorable tumor to breast ratio. It's a late recurrence, so I think we can do safely breast conserving treatment here.
Thank you. I would like to ask, I don't know who wants to answer this. The fact that she had 2 independent tumors in the same breast, does it raise any concerns about any predisposition to breast cancer? Would anybody think about it?
Good question.
Who wants to answer?
Michalis, I think even women with bilateral breast tumors don't look to have a really high risk of genetic mutations in the context of older age or no family history. So I would stay with the current guidelines.
So you wouldn't want to check it out whether she's at any. No. Okay.
If no, I can do it based on the new ASCO guidelines that recommend to check all women diagnosed before the age of 65 for BRCA1 and 2 mutations. But in my practice, I wouldn't consider this as a red flag in the context of no family history.
Thank you, Manolis.
Mihalis, because of the sake of the timing, can I pass
Yeah.
to the last one?
Yeah, let's move to the next one.
Okay, next one. So here we have this last case is a 42-year-old female patient, premenopausal. Again, 7 years ago, she had the operation, again, the same tumor, but this time in the initial surgery, she underwent unilateral skin-sparing mastectomy with an immediate implant reconstruction plus sentinel lymph node biopsy. Sentinel lymph node biopsy was negative, received chemotherapy and tamoxifen for 5 years. Today, again, the same scenario, but a recurrence under the skin. So 1 centimeter lump at the upper outer quadrant of the right breast, and mammogram, ultrasound, MRI, solitary mass, 13 millimeters underneath the skin, and ipsilateral axilla is normal, no family history, no gene mutation. Core biopsy said grade 2 ER/PR positive, HER2 negative, Ki 67.25%, and there is no systemic recurrence with the imaging. So the question here is, what is the next best step for the patient's management at the breast? Again, no surgical treatment, only systemic treatment. Local resection with removal of the implant, flat chest only. Local resection followed by reconstruction with implant or expander only. Local resection with removal of the implant, flat chest plus chest wall radiotherapy. Local resection followed by reconstruction with implant or expander plus chest wall radiotherapy. Local resection finally, plus or minus implant, expander, reconstruct, plus contralateral mastectomy. So please vote. This is a little bit complicated, more complicated than the previous ones. So let's wait for 15 seconds. Five more seconds.
Right. Okay.
Yes, let's see the results. Yep. There's no straightforward majority, but the choice 5, the local resection followed by reconstruction with implant or expander, with in addition to this, a chest wall radiotherapy was chosen by 37% of the audience. So who would like to comment on this? First as a surgeon and then the radiation oncologist.
Peter.
Peter.
Okay. Well, look, I think the most important thing is that we get clear margins on this lady. It's clearly more significant that she's already had a mastectomy, and it's you know, we know that not all mastectomies are the same. I would before surgery too. I would say that I'd probably do an MRI to see if there's residual breast tissue beyond that recurrence, because especially, you know, if I didn't do the operation, even if I did do the operation, I'd want to see that, because you may actually need to do a proper mastectomy again to minimize further problems. But I don't see a contraindication to reconstruction if it's possible technically, as long as it's feasible safely. I'll leave it at that.
Excellent point. Thank you, Peter. Last comment from maybe a radiation oncologist. Mihalis, can you help me?
If Dr. Margoudakis is with us, perhaps he could inform us of his opinion.
The lady has already been irradiated at the first time.
7 years ago.
Yes, that does not mean that radiation has gone. The radiation remains, and we have the term premature aging, meaning that the late side effects are keeping through the whole life. Now we have once irradiated the breast, and now we have expanded the skin, and we're asked to re-irradiate it. I am very, very cautious about that. What I would recommend, since we have the expander and the local excision, to see the margins, and if the margins are wide, then I wouldn't recommend radiotherapy. And if the margins are closed, I don't know what to do. That
And
would be
what if the sentinel node, redo sentinel node becomes positive as well? So that's also a issue in this, sometimes in these cases. I know this is very difficult.
okay. We have two difficult problems. One is to cover the axilla. The other is to see what's going to happen as a cosmetic result after we re-irradiate the underlying tissues. So this is a major problem for the.
Can I clarify? Did I miss that there was radiotherapy? Because I thought there was no radiotherapy.
There was no radiotherapy in the beginning, but that was a good point here. So that I didn't intervene.
No. Sure. Okay.
Yeah.
So if we have a positive lymph node, of course we have to irradiate the axilla. But what I'm afraid is in the case we have to irradiate the skin under the expander.
Right. So one final comment from maybe another surgeon. What about contralateral mastectomy here? 42-year-old, although the gene mutation is negative here. So would you still consider about staying on one side, not doing anything on the contralateral mastectomy?
Theodore, you want to take the mic?
I don't think that there is an evidence if genetic tests are negative to do anything. It's not a real prophylactic procedure, so it depends if she wants to or not. But I wouldn't go for a bilateral mastectomy.
Thank you very much. So this is all. Thank you very much.
Thank you, Bahadir. Thank you very much for these local relapse cases. Yazan, are you with us? Yes, you are.
I am. Let me
You
share
look
my
very
screen.
concentrated on your screen. So this is Yazan Mazanat with us. And he is taking part of this session. Again, local regional recurrence. I guess this will be about regional recurrence. Yes.
So it's more about the axilla. So the first case is
Regional.
recurrence, and the third case is an axillary recurrence. We can look at those. I've put a second one, which is not a recurrence, it's locally advanced in the axilla, but we'll see which ones we will discuss. Let's start with the first one. Let's see if my screen works. Can you see my screen all okay?
Yes.
So I think this is a true story. This is one of my last ladies before I left Aberdeen. A 65-year-old lady had her surgery about 10 years ago, had a mastectomy, T3 tumor, and had a clearance. And it was grade 2 ER positive because it was T3. They gave her chemotherapy. She had the radiotherapy. She had tamoxifen, switched for AI for 10 years. And then on switching, not on switching, when she stopped her AI, she came with a lump in the armpit. 6 months after stopping the AI. There's no family history, there's no associated diseases, otherwise everything was straightforward. And the lump was about 1 centimeter only, not a big lump in the axilla. It was palpable. She had contralateral imaging that did not show any abnormality. And there was only one node with a couple of, not sure about equivocal nodes close to it that were seen in the axilla, though she had a clearance before. And the core biopsy shows a similar picture to what she had before, which was a grade 2, strongly positive ER/PR and HER2 negative. So what would you next for her? What sort of imaging would you do for her? Let me see. I lost you.
So breast MRI only, staging, both breast MRI and staging, or nothing. Let's vote. Think this is quite straightforward. Let's see the results.
I think it's very straightforward.
Yeah. Good.
Now, I'll change the scenario and let's see if the vote changes. What if she had breast conserving surgery in the past? Same votes. So this time she had a mastectomy. This lady had a mastectomy. What if she had breast conserving surgery in the past? And then we'll discuss the votes.
Okay. Should we see the results now?
Perfect. So, and the second one, there is more on the MRI scan. The first one, there is less of MRI scan. I did not MRI scan her. Would anybody else, would they MRI scan this lady? Because she had a mastectomy and this was only in the axilla. We just did a PET CT scan to stage her. But I think the important thing here for her is that looking through her notes, she had a clearance, but it was an N0 disease. So that was a bit strange for me. And when we reviewed her scans, we found that she had a C5 axilla 10 years ago, but there was no positive nodes on the clearance. So is this really a true recurrence? I think that's the question. Any thoughts from anybody?
So MRI is even more important, more useful of
So,
the breast.
but there's no breast, so I did not do anything. Because
What about the other side?
So I did not do an MRI scan for her. I was happy with the mammogram and the ultrasound scan, and that did not show anything on the other side. Would everybody else MRI scan her?
I wouldn't. In the
Anybody
setting,
else? Any thoughts? I did not MR her. I did the PET only, and that showed me what I needed to see.
Mr. Tasoulis, you wouldn't.
No, I wouldn't. In the setting of previous mastectomy, I would not do an MRI unless there was a specific concern that there might be, I don't know, thick flaps, or there is any concern, as Peter said before, about the adequacy of the mastectomy.
Okay, good point.
I wouldn't
That's a
do
good
MRI.
point. Yeah, yeah.
The problem with the MRI scan, it can add more headaches from the other side and things, and will not always give you answers. This is a recurrence, not a recurrence. I don't think it was ever a recurrence. This is somebody with a very similar biology, and if she had showed something like a triple negative or showed something that's completely different, then we start picking something from here and there. But I did not MRI her. Oncology, any comments on that?
Manoli?
I wouldn't concern that. It's common to have false positive in the PET scan, although according to some new guidelines, when you have to perform staging, PET CT maybe is recommended because of the higher sensitivity for bone disease. I wouldn't consider that.
Now, what happened is that we put her through the MDT, and that was a discussion in the debate. Was this really a true recurrence? Will anybody consider this as a true recurrence, or this is the missed node that has been controlled by all the lovely AIs and tamoxifen for the past 10 years? And when we stopped her medication, then that started appearing again. So what would you do next? Will you give her chemo? Will you give her CDK4 and AI? Will you do her surgery, or will you start her on AR again?
Let's vote, please. Right, I think it's quite simple to decide. Let's see the answers, please.
Let's hear from the
Okay.
oncologists. Will any of the oncologists give her systemic treatment first?
Manoli?
No, I voted for chemo by mistake because I thought that
It's a reflex, I think.
No.
It's a reflex.
No. So I would go for surgery first, and then we can discuss the systemic treatment after.
And
So, Manolis, for the webinar, you vote for chemo, but real life go for surgery.
of course,
This is very medical oncology. This is very medical
No,
oncology.
no, no. It was by mistake, the vote, Michalis. No.
Okay, okay.
now
Right.
let's change the scenario and let's say that she had a sentinel biopsy that was negative, and this is maybe a recurrence. Or let's say she had a clearance in the past that was positive, and we consider this as a recurrence rather than a missed node. Will the vote be different? Will be interesting to see. Shall we vote again?
Remind us of the biology. ER/PR
Was-
positive.
It's ER positive, PR positive, HER2 negative, and initially it was a T3 tumor.
Okay.
So let's say that this is a true recurrence. We think it's a recurrence rather than a missed node that has been there for a good few years, controlled by AI. So let's say this is true recurrence. Will the choices be different?
But just to clarify, the initial tumor was a triple negative, wasn't it?
No. This was the ER positive, PR positive. It's similar biology, completely the same.
So it's a luminal tumor whatsoever.
Yeah.
Okay. From the beginning. Yeah.
From the beginning, luminal, there is no change in the receptors. The PR is slightly lower, but the rest is all okay.
The thing that changed here, is it a tumor that remained untreated since then, or it's a true recurrence? Does it change things? Let's see the results, please. Yeah, you see?
Slightly bit more for the primary systemic treatment before considering surgery. Oncology, would that have changed your mind?
Not really. This time I voted correct.
For surgery.
No. I understand, as I said before, your concern, but it's a speculation. No, I would consider that as a recurrence.
Just to mention that we actually do have evidence, kind of data about this. I think the CALOR study, which wasn't very well done, but it did indicate that the only patients that benefit from chemotherapy in this setting is patients that have ER low or ER negative breast cancers. So for ipsilateral recurrences. So I think if the receptors were slightly different, then we would definitely consider chemotherapy, bearing in mind that this patient probably had anthracyclines in the past.
That's a good point.
And
So if
this
it's triple negative or else, yeah, we would change our answer.
And what we've done, we've operated, we found 5 nodes, a couple were positive, the rest were all, the other 3 were negative. And we're quite happy surgically, they had the clearance on the redo clearance. So what is the next step of management? She had chemo in the past. She's not chemo naive. She had AI and tamoxifen for a while that were controlling the problem. So they were working in the past until we stopped them. What would you say that you'll do for this lady?
How old is she now?
She's 65 now.
65.
Yeah, she's relatively fit.
Right. I don't know.
So in reality, with regards to the adjuvant treatment system, I think we cannot offer her really a CDK4/6 inhibitor because we don't have any data for this type of patients that present with a recurrence. So CDK4/6 inhibitor were not really validated in this setting. Whether there will be a benefit or not, that's a different discussion. But I think for the sake of the fact that she's actually progressed very near the time of stopping from the aromatase inhibitor she was on, you would probably choose a different one. So technically, if she was on letrozole, you would go for something like exemestane, and then follow closely. I think that's probably what we will do. The question here is, could you go back to tamoxifen? Is it that this was keeping things at bay and then the change allowed this to happen or not? Again, it depends of how soon this happened. So I think probably a different AI might be an option. You could argue and say you could offer her as well as adjuvant bisphosphonates if she didn't have this at the time.
Would you consider chemotherapy?
That's interesting thing. There is no evidence for CDK4, but most people voted for that.
Yes, I think that's the natural response to trying to do anything you can for your patient. But technically, there's not a lot of data about this type of presentations with a single node, recurrence.
Perfect.
Would you recommend chemotherapy?
Not unless, as I said, if it was a different subtype. So if this was a triple negative recurrence, then definitely. If it was a grade 3 ER positive that had other features, maybe we would think about this. But even though, if you think about it, this patient had chemotherapy before, in the majority of the situation, and the timing that the patient was diagnosed with, I suspect that she would have been given anthracyclines and taxanes. Now, if you already had that, and we don't tend to offer anthracycline chemotherapy again for risk of cardiotoxicity, so therefore you will be left with suboptimal choices anyway, something like docetaxel and cyclophosphamide, which I'm not sure they would add significant benefit anyway. So probably
Okay. Noted. Yazan, I think we should move on.
So do you want me to do, this is more like a local advance to the axilla, which I think all what we've done is completely not what would people think would have done, but that's what we ended up doing. And there's a case of very similar to the previous one I took from Sophocles that was an ER positive, came back as triple negative. Which one should we go for?
I think, Yazan, just stick with the recurrence because this section is about
Shall we start with this?
recurrence. Yes.
Perfect. So the 62-year-old, I stole the case from Sophocles, so it's great that he's online. So she had a mastectomy in 2011 with sentinel node biopsy. Multifocal, though it was grade 1, it was multiple foci, all quite small, but she was ER80, PR strongly positive, HER2 negative with a Chi67 that's not high. On a sentinel node, there was 1 macro and 1 micro, and they've done a dissection that had some more positive nodes. So she had chemotherapy, she had AI, and she did not have radiotherapy. And 10 years later, she came with a relatively large axillary mass that shows completely different biology. It's a grade 3 NST, but this one is ER negative, PR negative, and HER2 positive. And there was
negative.
Yes.
HER2 negative, sorry. So she's triple negative. And the Ki67 was 20%, and the PET showed nothing else other than the axillary recurrence. So if we look at that lady and we compare to this one that we've done first, if you want to investigate her further, will you do any MRI scan for this lady? Any comments on that? Sorry, I don't know. My computer is there's no options. My computer is playing now. Just a minute. So will anybody do an MRI scan since it's a completely different biology? Will anybody look any further investigation for this lady?
Yazan, can you take us to the actual question because we cannot see?
I'm sorry, my computer is playing up for the past 2 days. Let me just try to sort it out. Okay, sorry. So what's the next best step for management for this lady? We consider that all her imaging was fine. We consider there was no other disease. The staging was fine. What will you consider to do for this lady? Are we looking at no surgical treatment, only systemic treatment? And systemic treatment, we're talking about chemotherapy with pembro, followed by surgery, followed by radio, chemotherapy and pembro, and if she responds well, followed by radiotherapy, no surgery, chemotherapy without pembro, followed by surgery plus minus radiotherapy, or we start with surgery first. We go back for upfront surgery for that 4 or 5 centimeter recurrence in the axilla, followed by chemotherapy and radiotherapy.
Okay, let's vote, please. Please give a bit more minutes before we vote.
Just to remind everybody that she never had radiotherapy before, so it's not a re-irradiation in this case, just as it used to be in previous cases.
So most of us, Yazan, chose to have
chemotherapy followed by surgery, followed by radiotherapy.
Everything.
Any comments
That is
from
everything.
medical oncology about this lady? Yeah.
So just to mention that
Medical
although
oncology?
so it's just saying that in essence we don't have any data for use of pembrolizumab in recurrent triple negative breast cancer, but we would still use pembrolizumab in the setting, mostly because of the fact that we know it's effective with regards to achieving a potentially a complete response. Now, with regards to that, I guess what you think about this in these cases is that, for example, in Keynote 355, there were also patients that were loco-regionally advanced and inoperable, so not necessarily truly metastatic, and they also did have a response. So I guess you can extend that as extrapolating the data with this idea in mind. So we do offer pembrolizumab, although 522 never included patients like this.
Manoli, would you give
for those ones that
pembrolizumab as well?
If you decide to go for systemic therapy and surgery, yes, I would incorporate pembrolizumab for sure.
And will you ask for a PDL1 for Pembro for this one if we consider it as a recurrence? Would that affect your decision or not?
Only if you consider this as a inoperable disease and go only for systemic treatment. Yes, in this case, it has some meaningful to ask for PDL1, but if your decision is the second one, then the addition of pembrolizumab is irrespectively of PDL1 status. So I wouldn't go for PDL2. I wouldn't check for PDL1.
Perfect. And
Good.
she had no previous radiotherapy, so radiotherapy is always an option. So she had excellent response, and she had chemotherapy, but she was not over Pembro, and she had complete radiological response, and she never had surgery. So if somebody has a complete response in an axillary recurrence, and let's say the area is marked, will you go back for the axilla and do more surgery there? Any comments from any of the surgeons?
I would go back to surgery.
And
Amit, what would you do? Difficult.
Well, I don't disagree with Yazan ever, but I'd be going back for surgery.
As I said, this is not my case. If it was mine and if she became operable, I would have gone back for surgery. But radiotherapy does magic on many ladies. Will all the other surgeons also go back for surgery?
I would
Peter?
go back,
Yeah.
I think.
Yeah.
Does it-
Why should we do surgery here? This is absolutely a salvage thing. So if this patient had a response to the neoadjuvant treatment, so there's only one reason to control axilla. If this axilla is controlled by anything else other than surgery, which we know that surgery, this will be a second surgery here, and it will cause some consequences in future for this lady. So I would say that I would not do surgery in this lady if it is proven that it is completely responded to the treatment. And I would keep the surgery for future if this patient has a secondary or a third time as a recurrence, then we may do a salvage surgery in this patient.
Can I make a comment?
Yes, please.
I would also favor trying to avoid surgery, but we do not have any data to suggest that there is any either imaging modality or combination of imaging and biopsy to accurately predict if there is any residual disease in the axilla. There have been some studies to look into core biopsy post-systemic therapy, but the false negative rate was in the range of 40%, which is completely different to data for combination of biopsies and imaging in the breast when we can perform a vacuum excision. So I would have put the clipped in the node. If it was axillary recurrence, I would go and take that single node out, trying to avoid unnecessary dissection in the axilla. Because if we did go for systemic therapy first and there is still residual disease, then the medical oncology team might want to know to tailor treatment afterwards. So that would be my thought process for this case.
So I think I agree with that. So if you're going to go for surgery, we're not going to do anything heroic. She had a clearance. So as long as the area is marked and you take that area and just have a look that there's nothing else, just to know what sort of response she had, because you have no problem in the breast to reflect what sort of response she had. So
Yazan, I have to interrupt here because we're taking too long of a time. There's no easy question for that. I remember I take my my message is take home message is what Dr. Tassouli said, which is if we had the magic tool to see if there is any residual tumor there, then would go back for surgery. If we're 100% that there's nothing left, then we could perhaps rely on radiotherapy and follow her up. Are we done?
I think we're done. Yeah, the computer is
Thank you, Yazan.
behaving now.
Thank you, Yazan. Thank you, Bahadir, for your time and for the presentation. I think it's time to move on to the next one.
Okay, I have the privilege to welcome to the podium Nicola Rocco, who's breast surgical oncologist in Italy, Napoli, Italy. So most likely he's here despite the nice weather that they probably have in Napoli this time, isn't it?
Yeah.
And he will share with us some oncoplastic cases in order to provoke some discussion about the surgical options and the diversity of approaches that many surgeons may have. So without delaying anymore, Nicola, the stage is yours. You can share your screen and you can carry on.
Yes, thank you, Sophocles, for your invitation, and good afternoon to all of you, to all the attendees, and to all the members of the panels. So we will talk about oncoplastic surgery and mostly oncoplastic decisions. So let's see the first case. We will have around 30 minutes, so we will have 3 cases we will discuss for 10 minutes each. So can you see my slides? Yes.
Yeah.
Okay, perfect. So my first case is this one. The first one is about this 40-year-old lady performing her first mammography. From this mammography, we can just see, our radiologist can just outline a nodule at lower inner quadrant on the left breast, and she also performed and several other dense areas on both sides, and she performed an ultrasonography, finding several suspicious hypoechoic areas. So we asked for a contrast-enhanced exam. We have, I see, yes, we used contrast-enhanced mammography more and more in our hospital, and this is what we find. So a very clearer view of the breast of this lady, and we performed a contrast-enhanced guided, 4 contrast-enhanced guided vacuum assist biopsies to this lady on both breasts. And well, we have a very particular scenario in which we had a DCIS at the upper outer quadrant, a luminal non-special type breast cancer at the lower quadrant in the periareolar retroareolar area on the right breast, and a lobular breast cancer at the periareolar area in the left breast, and a non-special type luminal breast cancer, HER2 positive, at the lower inner quadrant. So different biology of the disease and bilateral cancers. And it was a CT1C, so the largest nodule was the one on the left breast, the luminal one, the lobular one on the left breast. It was 18 millimeters, and the HER2 positive was 15 millimeter, and the luminal A on the non-special type on the right breast was 14 millimeters, and the area of the high-grade DCIS was of 14 millimeters. So we are talking about a bilateral multiple CT1 and 0 breast cancer. This is the lady. You can see this is a quite large breast. It's a medium-sized breast with some good level of ptosis. with a right sternal notch to nipple distance of 25 centimeters and a left sternal notch nipple distance of 25.5 centimeters. As you could see from the radiology, it is a type 3 breast according to the Rancati classification, because the distance between the gland and the skin is of more than 2 centimeters. And she had not special comorbidities and no smoking habit. So, and also no familiar history of breast cancer. So I would like to start with, before going to the first question, the first oncoplastic question, I would like to ask if we all agree, in particular, I would like to ask to the medical oncologist, if we all agree that this is a surgical patient, that we should go to surgery according to the biology of the cancer.
Dr. Angelis?
Yes. What is your opinion? So there is an HER2 positive disease of 15 millimeters on the left side, and then luminal cancer, PT1C on both sides, and 0.
So technically, she's a 15 millimeter HER2 positive breast cancer in one side, and which in essence you could consider actually offering her a neoadjuvant chemotherapy. The reality, though, is that she could also consider having adjuvant chemotherapy, which would be significantly de-escalated according to the APT study for that. Because if the disease was indeed 15 millimeters, so I think you definitely need an MRI to make sure that this is not a lesion that's bigger than 20 millimeters, as in that case, she would be able to access dual anti-HER2 therapy. But in reality, if this lesion is 15 millimeters, you could argue that you could proceed to surgery and then have chemotherapy with paclitaxel, Herceptin in the adjuvant setting.
Yes, thank you. So you correctly mentioned the role of MRI. So would you have all consider an MRI for this lady, or could you think that a contrast enhanced mammography could give the same information for this kind of patient? What is your opinion? I'm also asking to the surgeons, would you all go for MRI for a patient with a lobular cancer and HER2 different biology, bilateral multiple cancers? What is your opinion, Peter or Amit?
Thanks, Nicola. I'm going to let Amit answer too, but I'll quickly say that I think it depends on the expertise in the department. I think we've got increasing evidence that they're probably equivalent, and maybe contrast enhanced mammography may even have some slight edge over MRI. Certainly, it's technically easier for the patient in the case of biopsy, but I think we can say it's equivalent in expert hands. So it depends on experience in the unit, and I'll let Amit comment.
Yeah, thanks, Nicola. We will consider MR actually. Contrast is, we've got early experience, and as Peter said, we're finding it beneficial. So we'll see, but for now, we are very MRI intensive unit, especially given bilateral multicentric tumors.
Yes, I can understand your view, and I totally agree with Peter. It's also a matter of experience, and in our unit we are achieving a good experience with contrast enhanced mammography. So this is why, and we are one of the few centers using contrast enhanced vacuum assist biopsy under the guidance of contrast enhanced mammography. This is why we are using this kind of, but I can understand that MRI could be beneficial. Before going to the first question, I would also underline how we will ask about your opinion on how to surgically treat those patients. But obviously, every surgical oncoplastic choice is made up of a shared decision with the patient. So patient values and preferences should be taken into that account in our choice. So this is not real world. We are talking about cases and about the opinion of the surgeons and of the medical oncologists and radiotherapists, but always consider the opinion and the wish of the patients for all surgical choice. So let's go to the first question. So what kind of surgery would you consider for this patient? Bilateral, multiple cancers. Could you go for breast conserving surgery or this is a patient needing a bilateral mastectomy?
Nicola, did the patient have any genetic testing? Do we know?
She didn't have a familiar history for breast cancer, so even she was 40 years old, our medical oncologist did not ask for a genetic testing. No, she didn't.
Okay.
So let's wait some, even if this question is much more direct. So I think we can go for the results. Let's see what is the opinion. Oh, 50-50, very, very good. But this is what I expected. I would like to ask first from an oncological point of view. So from the safety of the breast conserving surgery for treating multiple ipsilateral cancers. I'd like to ask to a medical oncologist, to a radiotherapist, and to a surgeon, what is the opinion about the use of breast conserving surgery? Can I ask to the radiation oncology first? Can we safely consider breast conserving surgery and irradiating multiple tumor beds?
Dr. Margoudakis?
Yeah, what is your opinion?
Well, if we have clear margins after the operation, there is no problem to irradiate. But the thing is, we have to decide if this is the best solution for the lady. I mean, we have so many tumors, and the ball is at the field of the surgeons. If they decide that they would have a breast conserving treatment, then we can irradiate with no problems.
Perfect. So if surgically feasible, achieving clear surgical margins, we could go for breast conserving surgery. This is what you said. And I would like to ask to the surgeons, how would you, if someone of you considered breast conserving surgery, I don't know, but if someone of you considered breast conserving surgery, how would you have localized the different lesions? Did someone of you choose for breast conserving surgery, Peter, Amit, or Marios? No one?
Yeah, but somebody has to. I think somebody has to defend the
I did.
the 51%, the 51% of the audience that said breast conserving surgery.
Yes, no,
I voted for breast conserving surgery.
Okay,
Marios,
so
okay.
Marios.
Me too.
And Peter as well. He raised his hand.
So do you think there could be some problems in localizing these lesions? How would you treat this patient in your real life?
I think there are different localization, methods. You have to follow what somebody is familiar with and what they have available in their unit. What we tend to use, for example, is magnetic seeds, and we know that if the two lesions are too close to each other, then that might be a bit difficult to get a very good localization, in which case you can consider a combination of two different type of localization devices or a magnetic seed and a wire. But in a way, you have to follow what you're familiar with and what you have available in your unit. And
yes, thank you. This was my point. There could be some interference between different localization systems so close using them. What is your experience with MagSeed, or what are you using in your unit? I don't know.
I mean, if it is less than 3 centimeters, we tend to put a MagSeed and a wire, for example. If they are more than 3 centimeters, we use MagSeeds. And I have done oncoplastic procedures with 3, even 4 MagSeeds if they are in places to bracket the whole area, but more than 3 centimeters away.
Is there someone who who answered mastectomy in the panel? Amit, did you also consider breast conserving surgery?
No, well, I couldn't answer. The options went too fast, and perhaps I would have wanted to see patient choice, but
sure, obviously.
I was leaning towards a mastectomy, I have to say, if I were to answer.
Okay.
If I may, I think it's too much cancer in two breasts to just ignore that. I mean, it's cancer everywhere from the point I see it, and even from the imaging. So maybe I'm a little bit conservative, but I would have gone for mastectomy, to be honest.
Okay.
Yes.
Can I comment on that also? I need somebody to convince me not to do a mastectomy. I don't mind doing conservation on this lady, but before you conserve her, I would want to see genetics. She's in her 40s with bilateral cancers. And not only genetics, I want to see also the geneticist can give you a risk assessment, a lifetime risk assessment. And if she's in the moderate or the high risk, I would still be very worried about doing breast conservation. Yeah, maybe you're talking about cancer survival short-term survival might not be affected. But if this lady is going to do well, she will do well for years and years. And if she needs a mastectomy and reconstruction, you can do it at the same time. So I would really want the genetics. And the question for CEM or MRI scan depends on who we can report the CEM or the MRI scan. But there's some, though it's very little data for MRI scan, I don't think there is much data for picking the little extra foci for that CEM is superior at all or not. So I would just be worried about CEM. I would just do MRI scan. Tell me, Peter, you're raising your hand, so you must have.
Let's consider if she performed.
Two points.
Yeah.
So quickly, 2 points.
Thank
First
you.
of all, I'm surprised, Yazan. I thought you'd say the opposite based on your recent talks. Secondly, this lady we already know needs systemic therapy. It's a question of how much, but she needs it. She needs anti-HER2 therapy.
Yes.
Plus she needs endocrine therapy. So that's going to determine her survival. I think we need to get her treated surgically as quickly with as low risk and not delay systemic therapy. And that's the biggest problem that she faces with bilateral mastectomy, because no doubt she'll want immediate recon. And so I would think at this stage, at least, let's get the margins clear, get her to systemic therapy, and we can talk about genetics and maybe mastectomy reconstruction even before she has radiotherapy, given that she needs systemic therapy. We have time then.
But
I can tell that I agree with Peter.
But genetics will not give you any big information regarding local recurrence after local treatment.
But that's what I'm saying. She's in her 40s. We're not talking about local recurrence, local treatment. I'm not talking about the short term. And that stepped approach, I don't mind that. I've done it for a few times where you do the first surgery, genetics is done. If you think they're going to do well, then, and if they want to have mastectomy and reconstruction, we can do that before the radiotherapy as long as they finish all their treatments. But it's just, she's in her 40s. She has how many tumors in one breast and how many tumors in the other breast. So I don't know.
Well, I can tell you this is a very interesting discussion, but we should stay within time. So we will go to the next question. Okay. Next question is, so 50% of the panel and 50% of our attendees asked for a breast conserving surgery. So if going for a breast conserving surgery, what kind of breast conserving surgery would you have considered? A therapeutic mammoplasty, considering different pedicles, we will discuss on it. Or could you consider a round block, so a circumareolar approach? All the tumors were around the area of the nipple, so they could be approached also with this other kind of technique, with a Benelli one. So let's see, what would would have been your approach in a breast conserving surgery?
Can we see the results, please?
Yeah. Oh, again, not a clear choice towards one side or the other, but anyway, therapeutic mammoplasty. So in case of therapeutic mammoplasty, what kind of pedicles would you have considered? I would like to go back to the picture of the patient, if possible. Yes, I would like to make you clear where the tumors are. So who of you surgeons opted for a breast therapeutic mammoplasty?
I think Amit wants to speak.
Amit, what kind of pedicles would you consider?
Yeah, I consider therapeutic mammoplasty, and given the tumors are kind of occupying superior and supraomedial pedicle territory, inferior pedicle seems to be the easy choice, and perhaps you could get away with vertical scar mammoplasty as opposed to Weiss pattern.
Yeah, so an inferior pedicle or Weiss pattern or vertical mammoplasty. What is your opinion, Peter?
Yeah, I think certainly inferior pedicle definitely, well, I think certainly on the right. On the left, you could do a superior pedicle. That would be another option. One could map the neck as well, which would help. But I think, just looking at the patient, inferior pedicle on the right side and either inferior or superior on the left, whichever is going to work better given the extent of the cancer.
Did someone
actually on the left you could do a central pedicle as well, of course, so a sort of a septal pedicle. Yeah.
Obviously, I think we could all agree that it is a very tricky breast conserving surgery because you have to localize in order to obtain clear margins and negative margins. So someone answered for Benelli technique? No, I think no, but We had
It's-
around 43% of people in the.
Yeah, but Nicola is
yeah.
very versatile. I mean, with round
Yeah.
block technique, you can do whatever you like. So
So
most
it's
likely it's
also-
feasible. Yes.
It's also a matter of patient desire if she would like to have her breast lift up or reduced or not. But we don't know now at the moment. In this case, the patient wishes. So let's go to the third question. If we would consider a mastectomy, would you consider a skin-reducing nipple-sparing mastectomy or a free graft for the nipple? Or so a nipple-sparing mastectomy in the terms of free graft, not directly on a pedicle, or could you not consider the nipple sparing? So would you go for a skin sparing mastectomy, both a type 4 mastectomy or a standard skin sparing mastectomy with a Lausanne? Let's see.
So it's about the other 50% of the people who voted for mastectomy this question. And let's see, I think it's going to be 30, 30, 30. Let's see the results.
Let's see.
Yes, I'm right.
Yeah, a little bit of more people would consider a nipple preservation. So what do you think, Peter, Amit, or Marius? Would you go for a nipple sparing mastectomy, or would you consider, in order for as far as concerned with the characteristic of this patient, with the nipple distance, with the sternal notch nipple distance, could we safely spare the nipple? Also, from an oncological point of view, you can see where the tumors are located. Would you consider, for example, a frozen section in this case? What is your opinion, Amit?
Yeah, well, I voted for the first option.
Yes, but let's
nipple
consider,
sparing.
would you consider a mastectomy? What would you have done in this case?
Yeah, nipple preserving, skin reducing mastectomy. Yeah,
And would
we
you
don't
consider
have
frozen
access.
section during the surgery?
Yeah. We don't, in general, in the UK, frozen section is not very popular, in practice. So we wouldn't have that option, but equally, that's a discussion to be had with the patient, that we are making an attempt to preserve the nipple. Oncological being care is fine. If not, then we may have to come and excise, or we can always reconstruct.
So I think you are all based in the UK, so Marius and Peter, so you also do not consider frozen section in the retroareolar area.
I think Andreas is from Sweden. I don't know if Andreas is with us.
Is Andreas with us?
I mean, I can comment and say I would consider it, but would not have it available. So it's a matter of whether our pathologist would do it or not. But it is a useful tool if you can have access to it.
Yes, we do not routinely use frozen section, but when the tumor is so close to the nipple, we go for frozen section behind. Also because for this patient with a type 3 breast, we would have considered, in the case of mastectomy, a prepectoral approach. So I think it would be difficult and to perform an excision of the nipple in a second time with a prepectoral implant. Anyway, I think we should move to the second case for the matter.
So, but just for the curiosity, what did you do in this case?
Well, we performed breast conserving surgery, and we perform a supromedial pedicle on both sides with clear margins for all four cancers, and bilateral radiotherapy. So we opted for breast conserving surgery. So not with an inferior pedicle, but with a supromedial pedicle. Obviously, it was tricky. We used several MAC seeds, and two MAC seeds and ultrasonography for confirmation of the removal of, so intraoperative ultrasonography, both methods of localization. So
thank you very much for that.
Yes, thank you. So let's go to the second case. This is a 45-year-old lady without familiar history of breast cancer, and this is her MRI. You can see how there are more than one lesion on the left breast. The largest one is 21 millimeters, and there is also a wide non-mass enhancement area in the outer quadrants. You can see according to the Rankati score, this is closer, the gland is closer to the skin. So we considered it as a type 2 breast between 1 and 2 centimeters. We performed a biopsy, a core biopsy in the largest cancer under ultrasonography guidance. And we had a diagnosis of a lobular breast cancer, luminal A, 90% of estrogen receptors, progesterone 80%, Ki 67, 20%, with an HER2 2+ with a negative FISH. So a large lobular breast cancer, taking all the outer quadrants on the left breast. And this is the lady. So large breast, also in this case, according to our multidisciplinary meeting, no genetic testing was asked according to the negative familial history of the patient. And she has a right sternal notch to nipple distance of 27.5 centimeters and a left sternal notch to nipple distance of 26 centimeters. She had no particular comorbidities, no smoking habit. So large lobular cancer, taking all the outer quadrants of the breast in a large and ptotic breast. What would have you done? What kind of surgery would you consider for this lady? Or there are some comments before going to this question as for the...
No, it's okay. Then let's carry on with the oncoplastic thing. I think let's vote.
So, breast conserving surgery or mastectomy for this lady? Let's see. What is the opinion of the participants and of the panel? Okay. Well, strange. Very. I didn't imagine this kind of answer. So, 70% of patients would go for breast conserving surgery. Well, this is. I know this is a large breast, but I would like to go back to the imaging. You can see how all the half breast is taken by the contrast the contrast at the MRI, and is a CT2 multiple lobular cancer. So 70% went for breast conserving surgery. Who among the surgeons in the panel opted for breast conserving surgery?
Peter.
Marius also. Marius. So do you think that a lobular cancer could be easily treated in this kind of breast with breast conserving surgery?
I mean, if we accept the pre-op imaging to define the extent of the disease, and based on imaging and clinical examination, we feel that there is enough volume after an oncoplastic procedure to maintain an acceptable aesthetic outcome, I would go for breast conserving surgery.
We will talk about later with a further question about the technique you would use. So we will not go further with your opinion. But
I think Peter also Nicola. I think Peter also raises his hand.
Let's see.
I agree. I agree, and I won't talk about technique because you said you want to do that later. But I would also say that let's say there are significantly involved margins, and she does need a mastectomy at the end of the day. You've done no harm by setting up a template to reduce this lady's skin envelope, and it's then prepared, in fact, for optimal reconstruction. So we're not burning bridges by attempting breast conservation, even if it doesn't succeed. I completely agree.
Yeah, I can understand your point. So Amit, did you vote for mastectomy in this case?
No, I voted for breast conserving surgery as well, because to me, looking at the MRI, if I can see it clearly on the small screen, it's more of anteroposterior kind of layout of the lobula. So it is limited to the outer quadrants. So, so yes, I mean, if you have done bilateral multicentric cancers, we've done bilateral breast conserving surgery, certainly for unilateral.
I can understand your point. So let's see with the second question, what kind of technique would you have considered? So you all three were for breast conserving surgery. So therapeutic mammoplasty or even in a large breast like this, a chest wall perforator flap. So you are the experts of chest wall perforator flap. So I would like to understand if also in this kind of breast we could consider chest wall perforator flap, or is a breast for which therapeutic mammoplasty is the best option.
Can we
So
see the results?
let's
see the
see.
results. Yes.
Let's see. Yes. Okay. Yes. This is what I mostly expect. So 76% is in favor of therapeutic mammoplasty. But is someone of you in the panel for chest wall perforator flap? Amit or Peter or Marius, could you consider chest wall perforator flap for this kind of breast and this kind of tumor?
I mean, if I may go,
Yes.
I would say no. Because that's a discussion to be had with the patient, is that, look, because therapeutic mammoplasty does commit her to bilateral breast surgery for symmetrization.
Yeah.
And if she's not keen on surgery on the other side, or you cannot fund, or whatever may be the reason, then chest wall perforator flap is not an unreasonable option, even though we dominant practice is in a non-ptotic breast, but it's not an unreasonable option in ptotic breasts as well.
Well, what is your, thank you, Amit. What is your opinion, Peter or Marius?
Do you want to go first, or?
Yes, please.
I would say, just looking at the breast, there's significant ptosis and volume, and I would be favouring a secondary pedicle from the medial ptotic breast and central ptotic breast to, if necessary, to reconstruct any defects in the upper outer quadrant on the right. But if the margins were involved and it was maybe, going to be difficult to salvage, and she was very keen to avoid mastectomy, then maybe as a secondary procedure, I would consider adding in a flap, which makes it very complicated. But I wouldn't do a flap de novo in this patient, ideally, unless she absolutely refused symmetrizing, as Amit said. But I wouldn't be keen still.
Yeah, I can understand. I see that Yazan raised his hands.
I find chest wall perforator flaps in a ptotic breast quite disappointing results. So I don't know what Marius and Amit and Peter think. I find that the therapeutic mammoplasty gives them far better superior result.
I agree. Yes, I mean, we're saying as a plan B, certainly if I were to choose, if I were to pick for the patient, then I would pick therapeutic mammoplasty. But then if she, and as we said, if she doesn't want contralateral surgery, then yes, because flaps can hang, if they may not sit unless you've really got a long pedicle like LTAP or TDAP, that it really sinks into the cavity. There may be a bit of a ptotic component of the native breast plus a flap, and there may be a bit of a gap or kind of mound. So yes, I agree.
I also agree with you. So all of you answered for were in favor of breast conserving surgery, but let's imagine you would go for a mastectomy. Would you consider a skin reducing nipple sparing mastectomy? Would you consider large breasts, very long sternal notch to nipple distance? Would you consider a free nipple graft? Would you consider a skin sparing mastectomy? Obviously, part of the attendees were in favor of mastectomy. So what would have been your choice in case of mastectomy? Would you spare the nipple? Would you perform a nipple graft, or you could not spare the nipple? Let's wait 5 seconds more and let's see the results. Let's see. So, okay, skin reducing nipple sparing mastectomy. Well, now the panelists were in favor of breast conserving surgery. So I would like to tell you that we went for skin reducing nipple sparing mastectomy. We performed, I know the panelist at least knows that I'm in favor of the so-called triple pedicle skin reducing nipple sparing mastectomy, in which we can consider skin or nipple preservation also for very long distances from the sternal notch to the nipple. But then in the end, we performed the frozen section on the retroareolar ducts and they were positive. So we had to remove the nipple on the left side. So it was involved, even if there were no signs of involvement clinically and no clear signs at the MRI. So in the end, we could not spare the nipple in this patient, but I agree with the 52% of people who answered that we could consider nipple sparing mastectomy also for very large breasts. So I think Sophocles.
Nicola,
Yes.
may I ask the panelists? I mean, I would like the opinion of the surgeons. In case of the skin-reducing nipple-sparing mastectomy, which approach are they usually do they usually do?
Yeah.
I mean, which part of the skin are they epithelializing or using to reduce the skin? Peter?
Well, I was going to say to Nicola, I would send this patient to you, but she's already yours. But no,
Okay.
look, I think you have to read the Padula paper written by Nicola and his group. I agree. I completely do it in the triple pedicle. So I do a wise pattern deepithelialization, just to summarize what that involves, and then but I only enter into the breast and divide the dermis infralaterally to minimize the any sort of I don't go near the dermis of the neck. I leave the dermis of the neck completely intact circumferentially, because the more of the dermis you disrupt around the neck, the higher the risk of necrosis. And so that's the principle, and the paper outlines it very beautifully, and it works.
Nicola,
so
yeah,
can you show us something?
Yes, I can show you something. I just stop the sharing and share.
It's a tricky procedure, and I must say it is challenging, or I find it challenging, but I think it's a very safe.
I think these big breasts are a nightmare for doing these nipple sparing, skin reducing mastectomies in terms of which technique to choose and how to do it. Okay.
Yes, thank you, Sophocles. I will go briefly within this technique. I think all the panelists knows anyway. For the attendees, this is what I was talking about, the triple pedicle based nipple sparing skin reducing mastectomy that we combine usually with a prepectoral implant based reconstruction. As you can see from this picture, we completely deepithelize all the skin area within the Weiss pattern, and then we perform the mastectomy through the lateral axis at the level of the vertical incision of the vertical limb of the Weiss pattern and the superior lateral incision of the Weiss pattern. In this way, we completely preserve a superior, medial and inferior subcutaneous dermal pedicle for the nipple areola complex. So all the vessels coming through the subcutaneous tissue from the perforators coming from the inner mammary artery are preserved. All the vessels coming from the thoracoacromial artery and also from the lateral thoracic artery, and also the important ICAP flap. So at the level of the fifth, the ICAP pedicle at the level of the fifth intercostal space is preserved. In this case, we consider for this technique all patients with an external notch nipple distance more than 23 centimeters, a lower border of the areola to inframammary fold more than 9 centimeters. And in our first publication we published just last September, we only consider type 3 breasts for a prepectoral reconstruction. As we are expanding our use of prepectoral reconstruction, we are now considering for this technique also type 2 breasts. And as you can see with this patient, also previous periareolar incisions or previous radiotherapy or even need for post-mastectomy radiotherapy are not absolute contraindication to nipple preservation with this kind of technique. And obviously smokers are invited to stop smoking at least 1 month before surgery. Obviously, it's very, very important, as I always say, to consider breast anatomy when performing the mastectomy. You could see here the access to the mastectomy, and always look for the anterior lamina of the breast capsule. This will be the plane, the surgical plane you should follow in order to perform an oncologically safe and surgically safe mastectomy. In this way, the risk of leaving residual glandular tissue is very, very low, and the risk of not preserving properly preserving perforator vessels is very, very low. because the anterior lamina will also guide you to stay within the footprint of the breast and not going over the perforator or the perforators coming from the internal mammary artery. So then we close as a wise pattern, and this is a very important point. In order to properly use this technique, this is our ratio between the volume we remove and the implant we consider. You can see that there is a mean implant to mastectomy volume ratio of 50%. So if we remove around 700 grams of breast, we go for the use of a 350 cc implant volume. So we perform a significant reduction of the breast in order to properly use this technique. As you can see, we could lift the nipple up to 13 centimeters, and we only had 5 temporary venous congestions of the nipple and 2 superficial necrosis or epidermolysis of the nipple. So no complete nipple necrosis. And this is one of our latest results. So you could obtain very good results and reduce significantly your rates of complications in terms of ischemia and necrosis of the nipple. So use the triple pedicle technique. Do you think, Sophocles, we have time for the third case or not?
I think we can go through it and be quick on that, because we will probably skip a couple of cases from the last one or even all of them. So we prefer to hear more about oncoplastic surgery because we have covered most of the oncologic things. And I think we should take advantage of having you all here and hear more about oncoplastic surgery.
Thank you. Thank you. So if I manage to change the presentation, okay. So case 3. Case 3 is a 42-year-old BRCA1 pathological variant carrier. And I'm sorry, I'm showing you the imaging after the neoadjuvant chemotherapy. She had a CT2 M0 triple negative breast cancer at the right inner quadrants. And after neoadjuvant chemotherapy, she had a complete clinical response, clinical radiological response. You can see how there are indeed 2 clips, but I don't know why our radiologist put 2 clips, but it was 1 nodule in the lower inner quadrant on the right breast. This is also a type 3 breast according to the Rankati classification. And this is the, okay, so you can imagine what we use, because this is the patient I showed you in the presentation before. Anyway, so 42-year-old BRCA1 mutated patients. Right inner quadrant, CT2, CN0 triple negative breast cancer, becoming a CT0 N0 after neoadjuvant chemotherapy. And about her morphovolumetric characteristics, a right sternal notch to nipple distals of 29 centimeters, a left sternal notch to nipple distals of 27 centimeters, no smoking history, no comorbidities. So first of all, also involving the medical oncologist, would anyone consider breast-conserving surgery for this lady? Or do we all agree we would go for mastectomy? Let's first ask these questions and then we will discuss it.
I think it's going to be the only time that is not going to be debatable. Let's see. I'm quite curious to see if.
Yeah.
Can we hear the results, please?
Well, very strange, very, very strange. So we are about 50% of people, so 46% considering breast-conserving surgery for a BRCA1 mutated 45-year-old patient with a triple negative breast cancer and a complete pathological and a complete clinical response. So I would like to,
Nicola, can we get Mr. Salustros, because I'm saying he's getting a bit anxious about this answer. What do you think, Manoli? 46% of the audience here would have done what local excision or breast-conserving surgery? What do you think about it?
Not expected.
I am one of them, actually, Sophocles, and it's quite clear that we don't have to change our surgery for the index case based on the BRCA1 and 2 status. So it's there is a slightly increased risk of ipsilateral recurrence, but if we do the proper surgery plus radiation therapy, I don't think that we have to be so much concerned about the risk of ipsilateral recurrence. The story is totally different for the contralateral breast, so I voted for breast conservation, especially in the case of clinical CR for this lady.
Well, we know that.
I hope they understood very well your question.
Yes, yes. No, I would like to.
Because I was distracted by all these oncoplastic stories that I'm hearing now.
Yeah, this was the oncoplastic session, so this is why. But I would like to, yes, I also agree with you, because if we look at literature, we don't have any advantage in terms of survival using mastectomy in this kind of patients. With the first paper, it has been presented at, it has been recently published by Matteo Lambertini and other colleagues, and was presented at the last San Antonio, showing that in people under the age of 40, there could be a significant, could be an advantage in terms of survival with a bilateral mastectomy. But this was, anyway, this was a young lady, it was 45 years old. And what do you think could be the role of oophorectomy and prophylactic oophorectomy for this patient? Would you consider it? Would you go for breast conserving surgery and prophylactic oophorectomy? I'm asking to the medical oncologist.
The most important intervention for this lady is the bilateral salpingo oophorectomy to reduce her risk of an ovarian cancer, but more importantly, to increase the overall survival.
Yeah. So we are looking to overall survival, but
I am well aware of the data, by Matteo Lambertini presented and published in the Lancet, but I think that we have to be cautious regarding this data. There is a lot of bias. I am in selection bias in the decision of surgery, I guess, and this is supported by the fact that the control group, the group of the patients who did not have the surgery, did a very low. They had a very low disease-free survival rate. So I think that there was a selection bias based on the prognosis of the index cancer.
Yeah.
And that influenced the decision of the surgeon to go for more, surgery. And that was translated, of course, to better outcome.
I understand, but I would like to know the opinion of the surgeons. I see that Yazan raised his hand. Yazan, what is your opinion?
I just want to comment. Sorry, I'm joining my mobile because the computer crashed. Very similar to the other lady. It's not only about survival. So I'm not sure if I'm getting the point correct or not, but please correct me if I'm not getting it correct. This is a young lady treating the cancer that she has, and if it's a good prognosis tumor, I don't think mastectomy or breast conserving surgery will make a difference. But she will have high risk in the future. And if you have a good prognosis tumor and you feel that she's ready to have the risk reducing surgery, then you can consider it and talk about it. But I don't think that mastectomy or breast conserving surgery will change anything from her survival. But remember, it's not only about the cancer that she has. If she has another cancer in 5 years' time, just going through chemotherapy again, going through the treatments again is the main issue. So I think you need to have a more open discussion, like this lady and the previous lady, about risks, about treatments. We are not treating a cancer, we're treating a patient, and that's a big difference.
I agree with you. Yes, because facing again a new diagnosis of a new cancer will make into the nightmare again. So what is the opinion of Peter, Amit, and Marius? What was your answer? Was you in favor of breast conserving surgery or mastectomy? First, Marius, please.
Again, I think it's a very personal decision, and you have to discuss with the individual. There are two elements. One is how you manage the cancer, and the other is how you manage the risk from being a BRCA carrier. And depending on where the priorities are, what you would like to achieve at a given time point, then you make the relevant decision. Meaning that she has triple negative cancer for which is being treated. She might decide that she would like to proceed with the simplest option to begin with, and then consider risk-reducing surgery in the future, as Yazan said. But I do not have any specific preference, to be honest. I would be guided by the patient preferences.
Okay, I understand. I see raised hand by Salustros.
I would like just to clarify that it's a different discussion for a unilateral mastectomy compared to bilateral mastectomy.
Yeah,
Okay.
yes, this is true.
Can you
there's no
clear?
benefit from unilateral mastectomy.
If it's bilateral mastectomy, I agree with you that it's a matter of discussion. It's a matter of future cancer risk. It's different if you implement in the follow-up the MRI option for prevention. But if we stay to the discussion about mastectomy for the index cancer or breast conserving surgery, I think that the conservation has many good points to consider. It's different if you go for bilateral.
Yeah. So if we go for, would you be you would consider the contralateral mastectomy or not? I didn't.
I do. I would consider bilateral for sure, but not unilateral. But I would prefer breast conserving surgery if I decide to go only for the index cancer.
Okay. Thank you.
Okay.
I think we could go for the other questions. I thought it was a very one answer for 100% answer in one direction, but so never say never. But let's see. So if we consider mastectomy, and I see that more than 50%, around 50% did not consider mastectomy. So again, would you consider in a very large breast like this, but we already discussed it, but anyway, would you consider nipple sparing mastectomy, skin reducing mastectomy, what I showed you before, the triple pedicle, for example, or would you consider a nipple graft or a skin reducing mastectomy, a skin sparing mastectomy, as you could not preserve the nipple in these very large breasts? What is your opinion? Let's vote.
Can we see the poll box, please?
Let's see.
Okay.
Okay, perfect. Let's see the answers. So we are talking about a breast with a sternal notch to nipple distance of 29 centimeters and sternal notch to nipple distance on the left of 27 centimeters. Let's see
the results.
The results. Okay, so I convinced you about the triple pedicle. So we can spare the nipple, or at least this is my opinion. So 65% of you consider the possibility of sparing the nipple in this. And would someone of you, we are not talking about this particular patient in which we also had a cancer, but would you also consider for very large breast a staged procedure? So first considering a reduction and then performing the mastectomy. I think that, but Peter, do you consider staged procedures for very large breast? Is Peter with us?
I think
he had to go. He had to go,
okay,
actually.
okay.
So
what do you think, Marius or Amit, if he's with us?
Yeah, yeah, I would consider, especially because if the scenario presented was triple negative. So
yes, not in this case. I told in this case we could not stage the procedure. Anyway, in general, for very large breasts.
In general, certainly, let's say if this was risk reduction mastectomy, and then yeah, we would consider reduction kind of and let few months pass, 3 to 6 months minimum, and then we've got a nice envelope and everything is healed and can do nipple sparing at that point, kind of delayed immediate reconstruction.
Amit, would you use a Weiss pattern superior medial pedicle or superior pedicle or inferior pedicle? What kind of reduction would you consider as a first part of the operation?
I would consider the superior or superomedial pedicle. One reason, we could debate, but one reason is inferior pedicle is more of a deep pedicle. And if you're doing mastectomy and if your nipple is surviving on inferior pedicle, and then later on you're doing a mastectomy, which does take away the inferior pedicle, theoretical concerns, if you like.
Yeah, I agree with you.
So superior pedicle, which is a more stable pedicle, I guess, huh?
Yeah.
It's more superficial pedicle, so I would be more convinced that the nipple areolar blood supply would be more kind of assured.
Well,
Thank you.
thank you, Amit. So let's move to the last question. I think, okay, so some of you consider breast conserving surgery. Very large breast obviously is also a matter of patient wish about this choice. But anyway, in this very large breast, would you go for a simple round block technique to remove just the clip and some tissue around, or would you go for a therapeutic mammoplasty in a bilateral reduction? But I can understand it's also a matter of patient choice in this case.
Yes, indeed. Okay, let's see results.
Okay, 50-50, yeah. Yes, obviously, this is the right place for shared decision making. So if the patient wanted to reduce her breast, but we should also consider the risk of complications of a therapeutic mammoplasty compared to a very simple Benelli technique. We are talking about a triple negative breast cancer. We should not delay the treatment. So if we consider also breast conserving surgery instead of mastectomy, for some oncological reason, but also not to reduce the adjuvant treatments, we could consider the simpler technique. Anyway, so Amit, would you consider a therapeutic mammoplasty for this patient if the patient wishes for reducing also the breast?
Yeah, well, I'm biased towards therapeutic mammoplasty, yes.
And you would go for a supromedial pedicle?
Yeah. And that is my more of a default kind of pedicle, unless there's a reason I have to do inferior.
I agree with you. Marios, what is your opinion? Would you go for a therapeutic mammoplasty?
For this case, again, assuming that her preference would be to go smaller and change the aesthetic of the breast, I would go for therapeutic mammoplasty. But if the question is overall, and we're talking about someone who had an excellent response to treatment, I would not go either for therapeutic mammoplasty or Benelli. I would just do a simple periareolar incision and remove the area of the clip. So keep it completely simple. But again, we're discussing a different case now because it's BRCA carrier as well.
Yeah, so you were in favor of mastectomy. We didn't ask you for your opinion. Were you in favor of mastectomy for this patient?
No, we did discuss, and I think it is the shared decision-making process about whether the patient would like to have risk reduction surgery at the same time, in which case you would consider the bilateral mastectomy at the time of the therapeutic surgery.
Yeah, I understand. So, Sophocles, I think we concluded our oncoplastic discussion, and I hope people enjoyed our discussion.
Yes, Nicola, thank you very much. I mean, we can have a whole webinar about discussing about oncoplastic approaches. Well, the thing is that we found out that 50%, even in clear, straightforward questions in our mind, is not so straightforward, and there's a background for that. So it is never 100%, never 100%.
I was also surprised.
And the thing is that it's justified to be the other side, the other 50%. So thank you very much for the questions. They're all debatable, and that's why we didn't interrupt the session. We prefer to not do the last one, the miscellaneous, because most of the things we had in the cases, we actually discussed it previously. So before I give the podium to Michalis to sum up and say the conclusions, I would like to thank everybody for being here. First of all, I would like to thank all the people who attended and who have been here with us all this time, because this is what actually makes the difference, the contribution of the audience, and it's very valuable to have them with us. Of course, the panelists that they have been here all the time discussing all the cases. and definitely the presenters who made all this effort to prepare the cases, present and be here in a Saturday morning all this time. The IT people who have been all these years supporting us, and the organizing agency who has been every time, even 12 o'clock during the night that I'm sending them texts and everything, they're always there for us. So thank you everybody for being here with us, and especially the Hellenic Society of Breast Surgeons, the board, that they always support this effort. Michalis.
Thank you, Sophocles. As we said, we're going to skip the last session because most of them have been already discussed. It was an interesting, for one more year, an interesting webinar, I think. We rediscovered that guidelines are fantastic, but in real life, not nothing, but there are so many things that do not fall within the guidelines. If we want to make a quick recap of what we have discussed, and I repeat a quick because a detailed one will take a very long time. What I have written down here is that we learned about the methods of marking of the axilla in the cases where neoadjuvant treatment is needed, and we have agreed on what to mark, how many nodes we need to mark. We have discussed about the extent of excision in breast conserving surgery after neoadjuvant chemotherapy. We didn't agree on the number of markers we should put there. We discussed about twice, actually, about occult breast cancer. We disagreed whether a full mastectomy is justified as opposed to a radiotherapy to the breast. We discussed about advanced, locally advanced breast cancer, and we saw the presentation where the big lump of cancer takes the whole of the axilla, incorporating the vessels, and then what we do then, and what we do when we are in theater and we have to make a quick decision. We discussed about BRCA patients and how the BRCA-ness or the BRCA mutation changes not only the local treatment, but the systemic treatment as well. And that is why perhaps it's worth sending for BRCA testing even for people who are not choosing to have bilateral mastectomy. We discussed about how we're going to deal with the amount of disease remaining in the axilla after neoadjuvant chemotherapy, what is the meaning of macrometastasis and micrometastasis and isolated tumor cells, and whether it's worth radiating the axilla or not, and up to what level. We also discussed about types of reconstruction and how radiotherapy affects them, whether it's worth using a tissue expander, so a stage reconstruction, or direct to implant direct to implant reconstruction, even in cases where radiotherapy is going to be used. And finally, the use of MRI in DCIS, whether it's worth asking for one or not. We discussed about the omitting of sentinel node biopsy in selected cases, and we mentioned in SEMA trial and the SOUND trial. And finally, we discussed about recurrence, local recurrence and regional recurrence. This is an interesting case, although luckily the local recurrences are not common. There are hardly any guidelines to guide us to what to do, so it's always useful to discuss about them. And finally, Nicola, who won the championship, by the way, football champions in Napoli, if I'm not wrong. So well done, Nicola. Although you did not play, did you play? No, you did not play in the team. No, but well done.
Thank you.
We had the chance to dedicate a lot of time discussing about the options, deciding between mastectomy and breast conservation in borderline cases, and discussing about what type of conservation of local reconstruction of the breast will provide us oncological safety as well as a good aesthetic result. I think I have not forgotten anything. One last thing, we all know, or we haven't realized, that the brains and the soul behind this is Sophocles. And it's my privilege to have worked with him for 1 more year doing this. And I would like to thank you for my part as well. So thank you, Sophocles. It is a mistake if you think that Sophocles prepares it for 1 month or 2 months. Sophocles will start preparing the next one from when we switch off this webinar. So he will call me up and will say, okay, next year we'll do this and this and this. So he's preparing it for 1 year. So thank you, Sophocles, you go on.
I think he's exaggerating. Mikhail's exaggerating.
No, I'm not.
It's a teamwork and we're all in it. So
thank you everyone for being here. Thank you all the participants and all the panelists and all the speakers. Thank you all. Thanks.
Have a nice day. Thank you all.
Thank you. Bye.